Welcome to On the X. Today's episode is a compilation of some of the most honest conversations we've had around trauma, resilience, and what it actually takes to move forward after life hits hard. You'll hear from VA counselor Jeff Wiedenhofer from our series Mind Matters, along with Dr. Paul Conti and Taya Kyle, three perspectives that approach trauma from different angles, but all grounded in experience and reality. First up is Jeff Wiedenhofer. Jeff helps define trauma in clear, practical terms. What qualifies clinically, what PTSD actually is and isn't, and why many trauma responses are not signs of weakness, but the nervous system doing exactly what it's designed to do. His perspective sets the foundation for the conversations that follow. So here we go with Jeff Wiedenhofer on the X.
What that book defines trauma is, it defines it as someone perceives or actually experiences a threat to their life. And that's not just, your life, your breathing and your brain activity, but also parts of our body, our limbs, our skin, our sense of security. That's what trauma is. So when we talk about the diagnosis of post-traumatic stress disorder, it's a grouping of, I'll use the word they use, conditions that happen. And to be diagnosed with anything, certainly PTSD, a clinician who is qualified to do so has to go through the big blue book and basically check boxes. You have to meet criteria. And of course, all those criteria are going to be unfortunate things that are going on in your life. And I'll pause there. You have any?
So basically there's a checklist of things, right? Where it's like this, and are they all, is that checklist behavior that the person does? Is it things that a type of thing that has happened to them? Is it all of the above?
Well, I'm glad you asked, Chris. I think what I want to do today, I actually want to walk through them all.
Okay, perfect.
It's not that long. But I first want to kind of introduce post-traumatic stress. And I mentioned the definition of trauma. And I just want to talk about how the human system, and that includes all brain and physiological and neurological and organ functioning and system functioning, all that stuff has ways of accommodating for, and I'm going to use a phrase here, unacceptable emotional states. I know it's kind of a heavy topic here, but think about, if you've been to a funeral or something, and then you're at the funeral, and it's a loved one and you miss them and there's crying and there's things going on. And then you go out and grab some fast food afterward. When you're standing in line at the fast food restaurant, hopefully you're not sobbing your face off, right? You have to kind of pull it together, and something inside of you, whether you think you're deciding to or not, it just sort of happens that we just kind of, okay, stop. Crying stops, everything stops, and we pull it together and we order our food and interact with the person in front of us. But there's times when that stuff, those emotional states become so intense that it turns into behaviors that we can't really control or stop or manage to a healthy degree. And when I talk about emotional states, here's some examples. Fear, anxiety, anger, terror, and grief, right? These are all very painful emotional states. I think every human has experienced that to some degree. So we have this this highly developed conscious and subconscious instinct inside of us. It's innate to sometimes avoid all that pain. And I know I'm kind of getting in the weeds a little bit here. We can come back to define this. When something terrible happens to us or the people around us or a loved one, and that's what the DSM-5 accommodates for. It says, even if you hear about this happening to someone who's a very close person to you, you can get PTSD if you learn that something happened or almost happened to somebody that you know and love and is close to you. That terror, that's, and we've talked before about the sense of survival, right? It's all this protection mechanisms. It's not that someone's going crazy. It's that their system is protecting them in these states. So that's kind of what we're talking about with PTSD. And I'll go through the list here in a little bit, but do you have any questions on that? Am I making sense, or am I kind of moving around?
Let's just go through the list. Like if you have someone in your office or whatever, where someone's like, yeah, I feel like I have PTSD. What are the boxes you have to check?
So, yeah, I like what you said. And by the way, I do this all the time in my office with people. And mostly I do it with people who come in and say, no, I don't have that. They come in and say, I don't know what's going on, but I definitely don't have that. I know the woman today who's her brother was a ranger, Army Ranger in the 90s in the Persian Gulf War. We laughed about it today. She said, "Do you remember when I came in and said, I don't have PTSD, my brother does?" And so that's why I think going through this list helps. And I want to talk just quickly again with the DSM-5 and with diagnoses. It's important sometimes to talk about how we feel like we can be labeled sometimes. Like sometimes it's not a great feeling to be given a diagnosis, and it adds on to the negativity in our lives. Like, great, now I'm walking around and I'm different everyone because this doctor says I have this and he's making me go to these places. So I really want to normalize this, but also understand like it's just what the APA puts together. It's just trying to figure some things out. And when we try to group these conditions together into certain disorders, it helps us clinicians kind of organize how to address it as well. You know, somebody could come in and just be crying all the time and have all these things going on, and you could say, yeah, you are diagnosed with being a mess, you know, but that doesn't help. So that's why I want to mention that. And I'm really trying today, and this is the first thing I want to say about how we can learn to help people. I'm really trying to normalize post-traumatic stress with this language and say things like it's just innate, it's instinctual. And that's, you know, if anyone who's listening has experienced this or is around someone who's experienced this or knows someone who might be experiencing something like post-traumatic stress, boy, if you can just not add the pressure on of making them feel different and start learning the language around it and having discussions about, hey, it sounds like you're reacting to this terrible thing that happened like a human would, you know, I think that's important to mention. So I know I'm moving all around here. I'm going to come back to what the DSM-5 says about post-traumatic stress. So the first section, the first criteria is something has had to have happened. Directly experiencing or witnessing or learning about it happening to someone, a close family member or a friend, a threat of death, serious bodily injury, or sexual violence. That's straight out of the DSM-5. So that has had to have happened, you know. A lot of people throw around, you know, oh, that's my PTSD coming in. And yet that's fine. It's all good. You know, the diagnosis police is not going to find you and fine you. But to be diagnosed, you had to be in a situation where something terrible, threatening has happened or it's been seen. So the first, think about the phrase post-traumatic stress. That's what trauma, I just defined what trauma is. Now we're going to talk about what the stress is. So the first thing is associated with that event. There has to be some of the following: intrusive, distressing memories, or dreams, or dissociative reactions. And then the last two are psychological distress. Now we're talking about mental, emotional, internal stress, and physiological distress from cues about the event.
Mm-hmm.
So it's still remembered and it's still experienced and it still affects us. So far, everything I'm saying sounds pretty goddamn normal. If something awful happened to us, yeah, we're going to remember it and we're going to react to stuff that seems similar to it.
So let me go over a couple things, just my thoughts on a few things. The first is, I think, you know, I'm never a fan of calling mental health conditions, challenges, diseases. I don't like that because to me, it puts it in this pathology where the only solution is treatment of some kind. It's a very passive, it puts you in this passive mentality of, well, someone needs to fix me or something needs to fix me. And I always like the idea of empowering people. You have agency over these things, whatever it may be. You might be in a very serious condition that absolutely needs treatment. I'm not saying that, but that doesn't mean you have no agency over the whole thing. Like, you always have things that you can do as well, just like you can with physical health. So I say that because there are some people who rail against the term disorder. I've seen that before, where it's like, don't call it a disorder. And I'm not sure where that comes from exactly, because in my mind, I actually, of all the terms you could use, I kind of like that because it seems appropriate. It's a pattern of behavior that is disordered, that is not doing the right thing. And to me, that's empowering as well. It's like, okay, it's a pattern of behavior. You can change that pattern of behavior. We can change that pattern of behavior. So I happen to like that. What's your take on that? And have you had that pushback on that term specifically, disorder, at all?
Yeah. Yeah. I think when I was going through graduate school, it was really pushed to not really not ever use this as a label. That's the big
Mm,
problematic word. And maybe Chris, somebody like you who has really come to terms with what's going on and spent a lot of time looking at it, reflecting on it, and just seeing the reality of it. Maybe in that case, in cases like that, it can help because then now I can
yeah.
see what's going on. And like I said, it's a collection of conditions. It's not everything.
Yeah.
But now you can say, hey, let's address this in my life and let's have some kind of agency with it.
Next, we hear from Dr. Paul Conti. He is a psychiatrist, author, and expert in trauma and resilience. He has worked extensively with veterans, first responders, and civilians to help people understand how trauma affects the brain and what tools exist to recover and build resilience. Dr. Conti explains trauma as a hard science concept, something that physically changes the brain and challenges how casually that word gets used. He breaks down different types of trauma and introduces the idea of reflex versus response, helping explain where agency and healing actually begin. So we kind of use trauma in that way. We use the word to sort of define like an acute injury, so to speak. Like you break your arm, like that's a trauma to your body,
Yes.
kind of thing. And then we use the term to describe these sort of ongoing issues that people have, the ongoing psychological and emotional issue as a result, usually, of that event. Is that a good way to frame up that term? Do you think of it in the same way or a different way?
Well, a lot of it's similar, but I define trauma in a very hard science way. Now, often it's thought that trauma it's a soft concept. Anything that made someone not feel good now is a trauma. Maybe they're entitled to something. Like this is not what I'm talking about with this science. The way that we have advanced neuroscience has come far enough for us to understand that trauma changes us. So real and true trauma changes our brains, and our brains are different as we go forward. So our coping mechanisms are overwhelmed, and then our brains are different. It's the opposite of a soft concept, right? It's something that rises to the level where we are different afterwards. And that can come from something acute, which, as you said, they're the ones that are most clear and obvious, right? That there's been a death or an injury, or there's been an event, right? Something witnessed. But we can also get those brain changes from chronic traumas. Someone who's chronically denigrated, right, over time, chronically seen as less than, could be based on anything: race, socioeconomic status, sexuality, gender. There's so many ways that people can be chronically denigrated, right, and or seen as less than, right, by the world around us, and that can create the same brain change.
Okay.
Right? Just as vicarious trauma can create the same brain changes. So someone who's never been out of their hometown can inundate themselves with the tragedies that are going on, say in the Ukraine, for example, and then can become so impacted by that, seeing death and destruction and fear, that person's brain changes. So like the science knows this. There are acute, chronic, and vicarious traumas that change our brains. It's a hard science concept.
Okay. How much of that, I'm just curious, how much of those brain changes do we have, I guess, responsibility for, or can we impact ourselves? And the way I'm thinking of this is, let's say it's a situation like that, somebody who's repeatedly bullied over and over and over again. And if you had two people, one person might react by starting to think less of themselves and taking that on board and being traumatized by it.
Yeah.
Another person might be like, I don't care what you say to me.
Right.
Do it over and over. It doesn't matter.
Right.
So how much of those changes that happen to someone's brain is just like nature, like it just happens? And how much is an agency of it's how I'm reacting to that? Like I do have a choice in how I react. Even something like take the most egregious assault or something like that. Even that, how much of it after the fact, okay, the incident is over, not happening anymore, is a result of now how I'm reacting, right? And
right.
How much of that is a choice in that moment?
Right. Well, we often have a lot of control over that, but not always. Sometimes this the chronic traumas, for example, might happen in childhood, right? And the
Yes.
child just doesn't know. And is it empowered? The brain, does it come along to know, hey, that's not right, and I'm not less than. The child just knows they're getting beaten up at school every day, right? And they don't know there's a broader world out there, and like not everyone thinks this way, and these people are sick and unhealthy, and I'm not, right? But people, especially in childhood, don't have that ability, or the reflex can be so strong in us to trauma. So it was recently 30 years since my youngest brother died by suicide.
Mm-hmm.
My response to that inside was feeling shame and guilt, right? An automatic response inside. Now, at some point when I saw, like my thought processes are changing, my thought patterns are different. What I think about myself is different. Like I'm not handling life as well. I'm not taking care of myself like I was. Like I have to get help, right? But not everyone sees that, and we don't foster that in people. So
Yes.
the idea would be that we have helping mechanisms. Like no one told me. I never learned. I was a full-on adult. I hadn't gone to medical school yet, but I didn't know anything about this. That this tragedy has happened, and I'm trying to deal with the death of a family member, the impact on the family system. And by the way, it's like almost 100% predictable that there's a response in me that now I feel ashamed of myself in some way. I feel guilty. Why did this happen? And what does it say about me? And I'm dealing with all of that, the changes of self. So if we educated, guided both in true education and in how our medical systems, our healthcare systems handle this, then there would be outreach. And if you think, even if we only cared about dollars and cents, we would say there'd be so much less dysfunction, right? So many less presenteeism, people in the workforce, but not able to work. They're distracted by one thing or another. We would have outreach. We would think more about prevention and understanding, but we don't. So then we're relying on someone going and changing that. Like I remember at that time, it wasn't easy for me to go seek mental health care. I felt embarrassed about it. I felt there was something wrong with me that was going to be like made clear when I went to see someone. Right. And I also I was fortunate. I had insurance. So I could make some phone calls and I could navigate my way in. Like our society doesn't make it easy. Right. So I feel a lot of compassion for people who are in this place and they can help themselves, but they don't know that they can. Right. And yes, part of what you're doing and I'm doing here is like, let's bring that message to people. Right. But in a broader way, we could bring that message to people through education, through basic healthcare, just as we do with physical health.
Yeah. I think you use, I want to dig in on a concept there. I think you used the term, I think you said reflex, but I may be wrong on that. But I think of it as sort of reaction versus response in the way that, like, let's say somebody cuts me off in traffic and I have a reaction, like an angry reaction. And that reaction, in my estimation, is kind of a reflex. It's like, there's not a lot I can do there. Or like someone jumps out and scares me, that like feeling I get that, oh, that's a reaction. I'm really not in control of that. But the response to that, so it's like if 2 hours from now I'm still angry, or 2 hours from now I'm still scared, that's now a response problem. That's okay, I'm not processing this correctly. I'm not there's no immediate thing going on here. Is that fair to say that? Is that kind of a fair estimation?
Yeah, I think so. Yes, because there are reflexes, right? In that sense, reactions, right? And those are things that are automatic. So technically the word affect it refers to like emotion kind of things, right? But they're created in us without our choice. So if someone comes out and scares you, right, then there's what's called aroused affect. Aroused means it's created in you that you feel angry or afraid, and it courses through you as a reflex or a response before you're even aware of it. Right? So these things happen to us. Absolutely, they're reflexes and responses to things. They course through us. But the question I think you're directing us towards is what happens next.
Yes.
Right. So if you're aware, oh, someone cut me off in traffic, or someone scared me, or someone did something that really wasn't okay to me, and I feel afraid or angry or frustrated, but like it made that in me. Right. And now, man, it's 2 hours later and I'm still feeling that. Then you can start thinking about yourself and what you might do differently, right? But what if you're not thinking that, because the reflex or the reaction is so strong that you might think, oh, I'm an angry person, right? Or I'm
Mhm.
a less capable person. I mean, the reflex or response of guilt and shame after the loss of my brother, I didn't see where that was coming from. It felt like it was real, and I should feel ashamed and I should feel less than. Why did I think that? Because that's how I felt, right? And
Mhm.
without some help to direct my thoughts, is that really how you feel? Just like, how many people have I seen who've been assaulted by someone through no fault of their own? Someone came up behind them on the street and assaulted them. And that person then feels guilty and feels ashamed. I shouldn't have been there. I should have been wearing what I was wearing. I should have been looking around me. And
Yeah,
they
yeah,
would
yeah.
never say that to someone else.
Right.
Never say that to someone else. Let's say someone else who was hit over the head, who was assaulted, they're coming in next. Tell them how it's their fault. Person would never do that. They wouldn't do that to anyone on earth except themselves. Why do we do that? And
Yeah.
because we don't have the insight. If it's you, I can step outside of myself and I can see what's real and true and compassionate, right? If it's me, I'm often lost in that reflex, right? And then I feel the way that I feel, and I might feel that thing is my fault. I could feel that way forever
Yeah.
because I don't get a chance to step outside of myself and look at that. Hence, talking with someone else, journaling, meditating, the kind of things that get us out of ourselves so we can see ourselves, so we can separate reaction from response.
I want to pause for a moment and acknowledge a brand that's doing something you don't see very often anymore. GHOSTBED didn't just sponsor an episode. They stepped up to support the entire IRONCLAD network, and that matters. GHOSTBED is built by people who care deeply about quality. It's a product-first company led by Mark Warner, who still shows up every day obsessed with doing things the right way. Their mattresses are all made in America, engineered with advanced cooling technology, breathable materials, and zero shortcuts. They have 3 different collections to choose from, and they've built an online sleep quiz, so you can dial in exactly what works for your body. And behind it all is a real in-house team of sleep experts, never outsourced. Right now, we have an exclusive offer for our listeners that beats any other discount out there. Go to ghostbed.com/onthex and use code ONTHEX for an extra 15% off site-wide. When you support them, you're not just buying a mattress. You're supporting the kind of companies that keep independent, high-stakes storytelling alive.
And finally, Taya Kyle. Taya is the widow of Navy SEAL Chris Kyle. She's an author, speaker, and advocate who has spent years navigating profound loss while raising a family and helping others understand what resilience actually looks like after tragedy. She shares what it's like to carry trauma in the public eye and why PTSD isn't limited to one experience or one community.
He never saw combat. He never had trauma in or outside of military. This was not a PTSD case. And so, you know, that was so difficult for me that I couldn't say anything before the murder trial about that. And to this day, people think that, and it wasn't the case. You know, this is a guy who Chris thought he had it. That's what he was told.
Mm-hmm.
And so, as you know, shoulder to shoulder conversations instead of eye to eye are very helpful for people in trauma. And so if you go for a long drive, if you go shooting, if you go and do stuff that's like, we can talk, but we get to both be looking forward, it's really helpful. So yeah, we could have never seen that coming. I mean, that's, yeah, it's murder, right? Cold-blooded murder.
Let's talk about mental health, because I think it's something you've spoken about certainly in the book, and I think it's something that you have a very probably unique perspective on that other people might not. And we can go a bunch of different ways, but let's stick on the PTSD thing because, you know, again, it's something that gets talked about a lot. But from your perspective, there's sort of how has your attitude towards that changed over the last, like, whatever it is, 12 years or more, right? Because this is something that potentially could have impacted you as a couple while Chris was alive, right? Like he's coming back from combat and maybe there's some of that. Then there's this scenario where he's killed by a guy where that's potentially part of the equation. But then there's your own kind of PTSD or whatever you want to call it through all of this, right? And then there's there's also this added element to your story, which is not there for most people, which is it's all public, right? So it's like, you know, all of us have lost people, family members, teammates in my case, right? Like we've been through that in various, but to have none of in, you know, there's nothing that I've been through where it's like, it's in the public, and then there's, you know, there's a movie about it and all that kind of stuff. So there's that kind of added element. So yeah, how has your perspective on that changed? Let's stick with PTSD specifically in this case to start anyway.
Yeah. And by the way, I thank you for your service too. And I know you've gone through a lot of loss too. And it's awkward, probably when people say that, but I'm grateful.
Look, I appreciate that. I think I never knew what to say when someone would say that. It's like, because they say thank you for your service, and saying thank you back sounds weird. I think a friend of mine, another team guy, came up with the best answer, which was, it was my pleasure. I think that's the right way to respond.
Yeah. It's an honor to serve, you know, whatever.
Yes,
it's interesting.
100%.
I know I have heard some guys that have said, I didn't do it for you. I did it for the guys to the right and left to me, you know, and I'm like, okay,
I think that's a really
you know,
nice
right?
thing to say.
It may not be right, but I'm like, it opens up a little bit of a,
yeah, I mean,
it's awkward.
I think just to stick on this point real quick and to cut off your answer, but I think, it was my honor and my pleasure. I think it's like, sometimes it's lost that, look, it's a choice. No one forced me to serve. Right. And so it's not, there's no draft or anything like that. And so, hey, it was my choice. And when people say that, it's like, hey, you know, it was my honor, my pleasure, you know?
Yeah. I think that's a great way to answer. My pleasure is great. Okay. So PTSD, I have multiple feelings about it. And one of them that may not be very popular, is it is not just a veteran thing. And I say this because with our work with first responders, and there's so much with sex trafficking and drug trafficking, domestic violence, there are children who are raped every single day and they don't get a pass the rest of their life, but they have tremendous trauma. So I do feel, and I'm going to be sensitive to that issue because obviously my husband was killed by somebody who was claiming it to get something or to get away with or not do something. So on the one hand, I think, okay, so it is severe. It is real. It does change your life. It does change the way you react to things. It is challenging to live in trauma. It is life-changing to live after trauma. So it's our responsibility to dive in a little and to see that there are so many different ways to get help. Not every way is going to help for you. If somebody says, well, I don't want to go talk about it to somebody, I don't blame you. Then don't. What's next, right? Is it acupuncture? Is it yoga? Is it breathing? You know, like the deep breathing? Is it sound baths? Is it going for a walk and just sitting in nature for 30 minutes? Is it diving into your faith? I mean, there are so many ways that I have learned to heal that I want to encourage people to keep looking, to keep finding, and also that it's okay to want an escape. When you have trauma, I think everybody wants to escape. And the idea that you want to escape this life and kill yourself is reasonable. I feel like we have to get past the idea that that's somehow so horrifying. I think it's reasonable for human beings to want out of this life when it's too much, right? Who doesn't? So then it becomes, so now what do you do with that though? It's not this thing that you have to hold on and be quiet and be scared about. It's something that you have to say, I'm having these feelings like I don't want to live this life, and then allow people to sloppily go through it with you. It's not perfect, and we know that. And I think a lot of times people don't want to talk about it because they don't want to hear somebody go, oh my God, I'm taking you to a mental hospital, or I'm gonna, you know, you need help, or you can't. The thing that they need to do is tell me about that. What's going on? That's the best thing you can do, because if you overreact, that's why people don't want to talk about it, right? Because they don't actually know how they're feeling. So with trauma, I think one of the best things people can do is to hear what's going on. How do you feel? And then not try to solve it, not try to fix it, not try to get them out of it with encouragement. And this goes against me, by the way. Let me hear. Let's fix it. I know this, I know that. Let me get you to the right places. So I've had to learn primarily with McKenna, my daughter. We heal differently and we process differently. So to tell somebody what they should do is not right. Okay. So bear with me, because it's a I know I'm talking for a long time. I
That's
think
okay.
it's really
It's fine.
important. Okay. So after Chris was killed, and I just was telling McKenna, my daughter, this recently, I said, the governor and his wife, who were friends, said, there's so many people coming from out of town and out of state for this funeral. We will host you all at our house after the burial, just so you can take a breather before you head back home, right? Because it's 3 hours from us to Austin, where Chris was buried. And I was telling McKenna, she doesn't have all this memory. I said, I remember we're sitting outside on the patio, and you held my hand. You said, I don't feel good. And I said, I know, honey, I'm sorry. We'll be leaving pretty soon. And, she sat down and she had a fever, and I was like, oh, sitting with her for a minute, and then somebody would come up and I would say, oh yeah, thank you. And for me to be distracted is pretty good when I'm hurting. And there were guys that had Colton showing him different things. And when I retold her this story in the last 6 months, she said, that's so mean. And I said, what's mean? And she said, it's so mean for people to ask you to come to their house after you just buried your loved one. What we needed to do was go home and be together and be quiet together. And I thought, oof, right? She's 18 and her perception is so different. And, I was saying, well, they were just being so kind. They were being so open and loving and letting people grieve together instead of just, well, there's a burial. Now everybody go their own way. It was like a community to feel before we had to part. And what I've needed to do with her, Chris, is to say, yeah, that wasn't right for you. That didn't feel good to you. She went home and she had 106-degree fever for days. Yep, the doctor was telling me to watch, make sure her lips didn't turn
that's
blue.
high.
That she didn't have seizures.
That's like dangerously high.
Dangerously high.
Yeah.
She had a kidney and urinary tract infection. Her body just started to, it was like, I was changing a diaper on her. She wasn't getting up to go to the bathroom. It was very scary. The thing was, our bodies are going to get what they need. So her body needed to shut down, and we weren't shutting down. So her body did it for her. And so I have a very, by the
way,
mind-body connection.
Mind-body stuff, 100%. Yep.
Huge. There's so much about that.
Oh,
Yeah, it gives me chills.
100% agree.
And so as I've learned, so when somebody says, I have ideas I don't want to live, or they're in trauma, the best thing you can do is say, yeah, imagine so. Tell me about that.
Yeah.
And then when they say, well, I think this world sucks and whatever, yeah, I can see why you think the world sucks. That's so hard for me, because I want to say, yeah, but there's so many good things, or I want to tell them why they shouldn't be feeling so down, because they came to me for a reason. Don't they want me to help them feel better?
Yeah.
No, Taya, they don't. What they really need is for you to hear them and say, what do you need?
Yeah.
Right.
Yeah. Allowing somebody to express themselves. Right. Like, I think.
And validate it.
Yeah. Yeah.
Thanks for listening to On the X, the official podcast of the Navy SEAL Foundation and an Ironclad original series. Learn more at NavySealFoundation.org or text On the X to 60104. See you next time.